Isang Army trainee ang nasawi dahil umano sa heat exhaustion sa probinsya ng Isabela. Ayon sa militar, hinimatay ang 21 taong gulang si Jackson Lataan Manalog sa gitna ng training sa kampo ng 5th Infantry Division. Una siyang dinala sa medical hospital ng division pero kinailangan siyang ilipat sa Isabela Doctors General Hospital. Ayon sa doktor ay kinalaunan namatay si Manalog dahil sa cardiorespiratory arrest secondary to heat exhaustion. Bibigyan daw ng tulong ng militar ang pamilya ni Manalog. Git ng 5th ID, lahat ng kanilang recruit ay pumasa sa physical exam, dumaan sa mabusising selection process pero pinaimbisigan pa rin daw ang pagkasawi ni Manalog.
Hindi na natapos pa ng 23 anyos na sundalong si Randel Berin ang kanyang candidate soldier course sa Labangan, Zamboanga del Sur. Pumanaw ang Army training ng 1st Infantry Tabak Division sa gitna ng kanilang pagsasanay sa loob ng kanilang kampo. Base sa investigasyon noong January 10 ay tumakbo paikot ng kampo ang grupo ni Berin. Bigla raw nag-collapse ang binata.
Suddenly na natumba o na-collapse. Umaga yon, they're having the road run. It was a team run. Sabay-sabay naman silang tumakbo galing doon sa training school sa taas din papunta dito sa ruta nila. Then suddenly, according sa mga kasama niya sa team, bigla na lang natumba. Tapos nirush nila dito sa station hospital namin.
Habang itinatakbo sa ospital na wala ng pulso si Berin, agad namang sinubukan ng mga doktor na i-revive ang biktima. Nang ma-revive, inilipat siya sa ospital sa Pagadian City kung saan 4 na araw siyang comatose. Nitong January 14, idineklarang patay ang sundalo dahil umano sa hypoxic ischemic encephalopathy o pinsala sa utak dahil sa kawalan ng oxygen. Buong akala ng pamilya ni Berin, kakayanin niya ang training lalo't malakas naman ang pangangatawan ng binata. Hindi na raw ipapa-autopsy ng pamilya ang bangkay dahil naniniwala silang walang foul play sa nangyari. Nangako na ng tulong pinansyal ang Philippine Army para sa pamilya ng biktima. Sa susunod na buwan sana magtatapos si Berin sa Candidate Soldier Course ng Philippine Army.
Isang kadete ng Philippine National Police Academy o PNPA ang namatay matapos ma-heat stroke habang nasa training. Ayon sa pamunuan ng PNPA, hinimatay si Al-Rashid Macadato at 4 niyang kasama habang tumatakbo sa Oval mag-aalas 5 ng hapon noong Martes. Agad naman daw silang dinala sa dispensary para lapatan ng paunang lunas.
Pero si Macadato kinailangang dalhin sa ospital makalipas ang 2 oras. Doon siya binawian ng buhay kinaumagahan. Dagdag pa ng PNPA, walang hazing na naganap. Nagpapagaling pa ang iba pang kadete. Desidido namang magsampa ng kaso ang pamilya ni Macadato.
Kuha ang larawang ito noong nagsisimula palang buuin ni Pulis trainee Vanessa Teñoso ang pangarap na maging parte ng Special Action Force o SAF. Gusto niya kasing maging pulis tulad ng 2 kapatid. Pangarap na hindi na niya matutupad. Namatay si Vanessa kahapon matapos ma-heat stroke at atakihin sa puso habang nagtitraining sa Camp Vicente Lim sa Laguna. Ayon sa pamunuan ng National Police Training Institute o NPTI, biglang dumaing ng pagkahilo si Vanessa. Dinala siya sa ospital pero namatay din. Bago iyon, higit 2 oras din silang nakatayo sa init ng araw dahil sa kanilang training. Aalamin pa ng PNP kung may dapat imungkahing pagbabago sa training tuwing tag-init. Oktubre noong isang taon, isang police scout trainee ang namatay sa Agusan del Norte dahil sa matinding init.
Sa training kasi, merong standard yung physical exertion or physical test or agility test. Dapat ma-determine natin kung bakit nangyari yun. What is really the cause? Yung ba epekto ng yung ba may effect ba dun sa program of instruction na dati namang ginagawa na ng ating mga estudyante roon.
Naniniwala naman ang NPTI na tama lang ang ibinibigay nilang training. Tinitiyak nila na maayos ang kondisyon ng mga trainee ngayong tag-init gaya ng tamang physical conditioning, sapat na pagkain at pag-inom ng tubig. Mamayang gabi naman, iuuwi na sa Cagayan Valley si Vanessa. Caroline Bonkin, ABS-CBN News.
Isang police trainee naman sa Isabela ang biglang binawian ng buhay sa gitna ng physical fitness training. Ang itinuturong dahilan, heat stroke. Yan ang magang balita ni Julius Camba.
Matinding lungkot ang sumalubong sa pamilya Conag sa pag-uwi ni Police Trainee Loris Conag kahapon sa Piat, Cagayan. Wala ng buhay si Loris nang inuwi mula sa Police Training School sa Kawayan City, Isabela.
Kabata-bata niya, ganyan na ang nangyari sa kanya.
Hindi makausap ang misis ni Loris sa sobrang pagkabigla.
Clear na clear lahat ang medical niya, sir.
Ayon sa direktor ng Regional Training School ng Philippine National Training Institute sa Kawayan City, biglang nag-collapse si Loris sa kasagsagan ng physical fitness training nitong Miyerkules. Agad siyang isinugod sa ospital pero binawian din ng buhay.
Kataon lang siguro na yung panahon ay kahapon sobra init. Nung nag-exercise, bigla siyang nag-collapse.
Lumalabas sa medical certificate na heat stroke ang ikinamatay ng police trainee.
Nung March 13 po, sir, yun po, sir. Diretso po yun. Nag-marcha kami. Tapos nag-exercise kami, sir. Tapos dun po, sir, biglang na-collapse siya.
Nagsasagawa na ng fact-finding investigation ang pulisya sa Kawayan City para alamin kung heat stroke nga ang ikinamatay ni Loris o nagkaroon ng foul play. Julius Camba para sa Umagang Balita.
Military training, deployments, and missions often demand intense physical activity in extreme environments. Service members are often required to wear protective clothing, operate combat vehicles, and work in engine or boiler rooms. Medical and academic science shows the human body can tolerate extended exposure to most naturally occurring heat stress if given adequate water, shade, and a level of physical activity that matches the environmental conditions. Excessive exertion in the heat may eventually degrade mental and physical performance, resulting in exertional heat illness and sometimes heat casualties. Knowing the risk factors and mitigating them is important. Recognizing and heeding the warning signs and symptoms of heat stress and taking decisive action are all critical. Prevention awareness and immediate treatment ensure the health and safety of service members and mission success. This video will explain the signs, symptoms, and risk factors for different types of exertional heat illness. Demonstrate best practices for emergency treatment of exertional heat illness in the field, during transport, and in a clinic. And outline general steps for patient recovery and return to duty after an exertional heat illness event. Exertional heat illness is a spectrum of clinical conditions ranging in severity from mild to life-threatening. On the spectrum, heat exhaustion has signs and symptoms that are generally mild with a quick recovery. Heat injury has more clinically significant signs and symptoms. Exertional heat stroke is the most serious with risks for a long-term and possibly permanent end organ damage. EHS, if not managed aggressively, is a potentially fatal illness. Let's consider the signs, symptoms, and laboratory findings for each condition. Keep in mind that a service member does not have to pass through heat exhaustion and heat injury first, but can immediately develop exertional heat stroke. As with other clinical conditions, exertional heat illness will come with signs and symptoms. Signs are objective and can be observed by the provider, while symptoms are subjective comments and complaints by the patient. Heat exhaustion is characterized by signs such as tachycardia, orthostasis, diaphoresis, flushed skin, and most notably a rectal temperature equal to or greater than 101 degrees Fahrenheit and less than 104 degrees. Symptoms of heat exhaustion, as reported by the patient, may include mild headache, nausea, weakness, dizziness and tingling of arms and legs. Exertional heat exhaustion usually resolves rapidly on removal from the heat and minimal cooling intervention. Service members typically make a full recovery with a rapid return to duty likely. heat injury is more severe than heat exhaustion. The primary signs and symptoms for heat injury are the same as heat exhaustion but may be more pronounced. Clinical evidence of end organ injury, including acute kidney injury, liver injury, or rhabdomyolysis, may be noted. Immediate steps must be taken to begin cooling and support organ function as appropriate. Exertional heat stroke is a life-threatening condition. Commonly, the patient collapses. The rectal temperature is usually equal to or greater than 104 degrees Fahrenheit. Additional signs include tachycardia, hypotension, diaphoresis, unsteady gait, combativeness, delirium, confusion, convulsions, or coma. If these signs are noted but temperature is normal, other potential causes need to be considered. In military settings, one relevant cause is exertional hyponatremia or extremely low sodium level. There is a risk of significant end organ injury, including cardiac arrhythmias. EHS can progress to a sudden, multi-organ dysfunctional state, evidenced by a systemic inflammatory response syndrome, disseminated intravascular coagulation, and liver failure. Urgent steps must be taken to cool the service member immediately and begin life-saving supportive interventions as clinically indicated. Exertional heat stroke occurs infrequently in service members, but must be urgently recognized and treated when it does occur. Otherwise, it can result in a service member fatality. Exertional heat stroke remains one of the most common causes of preventable, non-traumatic exertional sudden death in the military. Between 2010 and 2015, the number of EHS incidents remained relatively consistent. More males have an incident of EHS than females, and they are often 20 years or younger. Exertional heat illness occurs most often with young military service members who have a limited state of acclimatization. It also occurs when there is a mismatch between their level of fitness and training, the intensity of activity or exercise, and the environmental heat load. But all service members, young and old, fit and less fit, are potentially at risk, and leadership needs to be alert to the signs and symptoms. Risk factors for heat illness can be divided into defined categories. Intrinsic or non-modifiable risk factors may be congenital, genetic, or may be acquired. Extrinsic or modifiable risk factors include fitness level, body mass index, state of acclimatization, sleep deprivation or fatigue, hydration status, recent or concurrent illness, use of medications, dietary supplements, alcohol use, environment, clothing, work efficiency, and the operational tempo of the activity. In military settings, physical activity, protective gear, and conditions like high air temperature, high humidity, low air movement, and radiant heat from the sun all contribute to the environmental heat load. Human sweat glands are designed for cooling, but the sweat must be able to evaporate. Sweat that drips off the body or soaks clothing provides no cooling benefit. Under extreme conditions of exertion in the heat, even healthy, well-acclimated, and physically fit individuals will ultimately store excessive heat, which will cause the body temperature to rise. Some service members are not able to sustain work in the heat. Their body temperature starts rising earlier and at a higher rate than others under the same conditions. They may not be adequately acclimated, or they may just be heat intolerant. There is no way to know if someone is heat intolerant until symptoms of heat illness appear, so awareness and prevention are key. Prevention of exertional heat illness can take many forms. The wet bulb globe temperature, or WBGT, is used to estimate the magnitude of environmental factors and heat stress on humans. Factors including air temperature, humidity, wind speed, and visible and radiant heat, such as sunlight, are measured to determine WBGT. WBGT results, shown as a heat category, are used to determine fluid replacement, physical activity levels, work-rest ratios, and clothing adjustments to minimize risk and maximize performance. Heat stress and dehydration can accumulate over several days. Fluid replacement and work rest guidelines consider the WBGT heat category, the level of work, required uniform, and other factors to sustain performance and prevent heat injuries. In certain situations, fluids required to replace sweating may actually exceed the body's ability to absorb the fluid. Significant heat acclimatization requires 3 to 5 days, while full acclimatization can take a week to 2 weeks. Acclimatization usually requires at least 2 hours per day of carefully supervised exercise in the heat with gradual increase in the exercise intensity. Even with the best prevention strategies, some service members will experience exertional heat illness. Science and medicine show that immediate treatment is critical. Early cooling leads to decreased morbidity and mortality. Heat stroke survival rates are directly related to the duration of the hyperthermia. Immediate treatment allows most service members to quickly recover and return to duty. The prognosis is much worse when early intervention is delayed and the internal core temperature remains above the critical threshold for any period of time. Unrecognized and untreated exertional heat stroke is often fatal. Promptly recognized and rapidly cooled patients with exertional heat stroke show markedly improved survival rates and reduced complications. No training or guide can cover all possible situations in which a service member may develop exertional heat illness. Your location, climate, environment, activity, and available equipment are factors you need to consider in your treatment plan. If you suspect exertional heat illness of any severity, initiate cooling. Use aggressive on-site cooling if necessary. Prompt treatment can mitigate progression of mild heat exhaustion to severe exertional heat stroke. Keep a mindset of prevention even during treatment. This video shows the best practices for treatment of heat illness in military medicine for emergency treatment in the field, during transport, and in a clinic location. The specific policies of your branch of service or your unit may vary, but generally accepted medical standards are applied for treatment of exertional heat illness. The severity of the exertional heat illness may not be immediately apparent, so core temperature must be determined. Rectal temperature is the most consistently reliable and valid way to measure core temperature.
10.06. All right, let's go ahead and start active cooling.
But do not delay cooling if EHS is suspected and rectal temperature monitoring is not possible. The fastest cooling for treatment of EHS is whole body, cold water immersion with the water aggressively stirred. In some training and operational environments, this is not practical or possible. Depending on resources and physical location, other cooling strategies include arm immersion in ice water, cold water showers, ice sheets, or the ice burrito technique. These strategies should be used to initiate cooling before transfer to a medical facility. Imagine your unit is in the middle of training or work, and a service member begins to show symptoms of heat exhaustion. These may include headache, nausea, weakness, dizziness, and complaints of tingling in the arms and legs. The service member may have mental status changes and be unable to follow commands. Step 1. As you begin treatment, have someone call for support in transport.
Hey, go ahead and call Sergeant Rod, man. Tell him, man, I think Sergeant Dillon, man, has a heat exhaustion.
Sergeant Rodriguez, go ahead and bring the medical kit to the finish line.
Roger, that's a good copy. I'm on my way.
Activate EMS. Be aware of the ABCs and basic life support. Step 2. Assess the physical and mental condition of the service member by asking questions with specific answers. Ask, what day of the week is it? Or, what is your birthday?
All right, are you okay? Sergeant Dillon, what is today? What's today, man? What's today?
Friday?
No, man, no. Hey, hurry up, Sergeant Rod, man. Run in here, man. Hey, help me out.
Step 3. If symptoms of heat illness are present, help move your service member to a safe place to lie down on the ground in a shady place if possible. Step 4. Remove the service member's excess clothing.
Hey, look, let's go ahead and remove Sergeant Dillon's clothing, man. Remove his top. Remove his top.
Take a core body temperature with a rectal thermometer if available. If you are unable to obtain a rectal temperature and clinical suspicion remains high for diagnosis of significant heat illness, initiate immediate and aggressive cooling. Do not wait.
All right, go ahead and give me the ice sheet ready. Give me the ice sheet ready.
A pulse oximeter can be a useful supplemental tool in a collapse situation, but its use should not delay aggressive cooling. Step 5. Begin the cooling protocol. Dip the sheets into the ice water slurry until they are thoroughly saturated. Open the sheet fully. Wrap the sheet around the service member, covering as much skin as possible. Wrap the sheet underneath to create an ice burrito. Wrap an ice towel around the head, covering the top of the head. Be sure to keep the first ice sheet in place, and then add an additional ice sheet over the first. Remove the secondary ice sheet and towel every 30 to 60 seconds, and put it back into the slurry. Replace with a new ice sheet and towel. Step 6. Continue with ice sheets. Assess and monitor vital signs every minute for mental, cardiac, and pulmonary status. Continue to monitor rectal temperature if available. If the patient is confused and body temperature is normal, exertional hyponatremia should be considered. Exertional hyponatremia is an abnormally low level of sodium in the blood. It typically results when the sodium lost from sweating is not replaced and significant amounts of water or other fluids are provided. If a rectal temperature cannot be obtained, exercise caution with IV fluids. Give IV fluids at a rate of not more than KVO or keep vein open, pending the results of an urgent blood sodium test. Overly aggressive use of IV fluids can be fatal. Patients may become disoriented or combative due to heat stroke. Placement of ice packs can vary, but if ice packs are available, place them behind the neck, one at each upper arm region, one at each femoral artery, and one behind each knee. Loose ice and cold water can also be applied. Use the supplies you have available. Step 7. Continue cooling until the rectal temperature shows between 102 and 102.5 degrees Fahrenheit. If the rectal temperature is not available, continue cooling until the arrival of EMS or the patient begins to shiver. Some service members will need to be transported for further cooling or for medical treatment and follow-up.
123, checkpoint 3, heat case 105 and rising, en route to medical. How copy, over.
Cooling efforts should continue if possible during transport. Time is of the essence. Continue to monitor vital signs, and if possible, start an IV if it hasn't been started already. Chilled IV fluids can be considered depending on your MTF's local guidance. At medical treatment facilities, a protocol for treatment of heat illness should be established in advance of any patient arrival. Assemble medical equipment required to treat heat illness or create a list for quick reference. Define a team of providers and a system to contact them for immediate response. Identify a team leader and other key positions and responsibilities. Resources may vary at your location, but keep in mind these best practices for medical care. Step 1. When the MTF is contacted about an incoming suspected heat stroke patient, assemble the team of providers, equipment, and ice to a defined location. Step 2. Upon arrival, the next steps may take place simultaneously depending on the number of personnel and the cooling strategy. The preferred methods for cooling are ice water immersion and ice water dousing. If these techniques are unavailable, ice packs can be utilized. Immediate attention must focus on the ABCs with basic life support. An AED or automated external defibrillator should be readily available. Take the rectal temperature and use a continuous monitoring thermometer if available.
Temp 103.5. Temp 103.5 I.
IV right AC 20 gauge. Keep vein open.
Step 3. Take other vital signs. Assess physical and mental condition of the patient. Record all vital signs and rectal temperatures. Draw a blood sample and take it to the lab immediately for a predetermined heat panel. Start an IV if not already initiated. complete a finger stick glucose test, and an urgent blood sodium level. The rate of IV fluids should be determined by the patient's clinical presentation with special attention to the serum sodium level. Patients with a low serum sodium level who are at risk for exertional hyponatremia require a cautious balance of IV fluids. The input of a trained specialist and administration of hypertonic saline may be needed. In the case of exertional hyponatremia, overly aggressive hydration via IV fluids can lead to brainstem herniation or death. Step 4. Remove all excess clothing and begin an aggressive cooling protocol. Some treatment facilities leave on underwear or light clothing to hold ice packs in place. Placement of ice packs can vary, but be sure to put them behind the neck, one at each upper arm region, one at each femoral artery, and one behind each knee. The ice pack behind the neck is important. Hold the ice packs in place if needed. If available, use misters or spray bottles with a large fan. Moving the air is important to cooling. Ice sheets and ice towels can also be used. Continuous access to the body is critical when cooling. A mesh stretcher is recommended as it allows air and water flow, quick movement of the patient, and easier access in the event an AED is required. A pool or tub can also be used. In the event of cardiac arrest, however, moving a wet patient from a tub and drying them quickly can be difficult. There is also a risk of contamination from bodily fluids. When a patient is in a pool or tub, ladle the cold water up and over continuously. Step 5. Assess the patient continually for mental, cardiac, and pulmonary status. Heat stroke patients have highly variable clinical presentations. Some may require intubation, while others may require the use of an AED for cardiac arrest. Some patients may progress to coma. There is no definitive algorithm except to monitor continually with a focus on ABCs, clinical information, and labs. Patients may become disoriented or combative due to heat stress. A mental status change of this nature may occur and is considered an emergency. Follow the protocol for your location, which may include calling additional staff for assistance in restraining the patient if necessary. Step 6. Continue cooling until the rectal temperature shows between 102 and 102.5 degrees Fahrenheit. Immediate follow-up care may include an EKG, a chest X-ray, and a urine sample with other labs ordered as clinically necessary. Someone should accompany the patient at all times to be sure there is not a clinical relapse. What happens after an incident of exertional heat illness is directed by ongoing clinical lab results, medical observations, plus conversations with the recovering service member.
How are you feeling since you went down? A little better? You were kind of out of it, a little combative there for a little bit?
I don't remember anything.
You don't remember anything?
I just went for a run and then...
Depending on the severity of the incident and other factors, immediate next steps may include a return to quarters, a period of observation, or transfer to a higher level of care. Laboratory follow-up includes a blood panel repeated at defined increments. Researchers believe that persons who have had an incident of heat illness can be more prone to a relapse or follow-up incident. Typically, the clinical course of exertional heat stroke follows 3 distinct phases in the hours and days following. Acutely, the service member should be assessed for changes of the central nervous system, gastrointestinal, pulmonary, and metabolic systems, as well as a systemic inflammatory response syndrome. Hematologic and enzymatic disorders peak in the 24 to 72-hour period after the incident. The service member should be watched for disseminated intravascular coagulation and rhabdomyolysis. Late impacts at the 3 to 5 day mark may include liver failure or acute kidney injury. In some cases, it can take several days for other serious issues to surface.
Okay, so I want you to just kind of take it easy today, all right? We'll have you come back in again tomorrow, all right? So I'll see what the lab results are today. We'll talk about those tomorrow when they come back in. In the meantime, make sure you're drinking plenty of water, okay? Getting plenty of rest.
It is important to note that not all EHS cases progress through the 3 phases. Early cooling may avoid clinical deterioration and the complications may be avoided. Clinical decision-making requires experience, anticipation of potential complications, and a skilled medical team.
Dr. Helmendahler. Sir. How are you feeling today?
All right, sir.
Doing okay? So you were able to get a little sleep last night?
Yes, sir. Hey, Doc, I'm feeling pretty good. Am I good to get back out and train?
As for return to duty, it will be directed by service-specific guidance. In addition, some local treatment facilities and military schools or training programs may issue their own requirements. But 3 core elements are common to all return to duty decisions: an established diagnosis, a return to normal state from an end organ injury, a period of recovery that allows for exercise and heat acclimatization. For the purpose of follow-up and medical evaluation board determination, the service member will be reassessed weekly for presence or absence of both complications and contributing risk factors. Return to duty is generally driven by the service member's recovery during the 2-week period following the event. The service member's status will be classified into one of 3 categories. First, heat stroke without sequelae or other complicating conditions. This is defined as having all clinical signs and symptoms resolved by 2 weeks following the event. The second category is heat stroke with sequelae, which is defined as having related medical concerns that do not completely resolve by 2 weeks following the event. This may include any evidence of cognitive or behavioral dysfunction, renal impairment, hepatic dysfunction, or rhabdomyolysis. The last category is complex heat stroke, defined as recurrent or occurring in the presence of a non-modifiable risk factor, either known or suspected. Service members demonstrating certain criteria, despite 2 weeks of rest, should be referred to an appropriate specialist. Heat tolerance testing, or HTT, is utilized by special operations personnel for certain candidates who sustain a severe heat injury. The Consortium for Health and Military Performance, or CHAMP, at the Uniformed Services University of the Health Sciences currently conducts HTT as a research tool. The HTT is recognized by the American College of Sports Medicine for some heat illness cases where return to play is difficult. At CHAMP, the HTT involves a 2-hour test in a heat chamber with continuous monitoring of the service member's heart rate, skin temperature, and rectal temperature both before, during, and after the test. Heat tolerance is demonstrated by a rise in temperature to no more than 38.5 degrees Celsius or 101.3 degrees Fahrenheit, with a plateau in body temperature dynamics. The heart rate must also stay below 150 beats per minute during the test. Heat intolerance is demonstrated by a heart rate that exceeds 150 beats per minute or a maximum temperature of over 38.5 degrees Celsius. When the temperature rises to this level, it typically means that the service member also has not demonstrated a plateau in body temperature dynamics during the test. Heat tolerance testing is used as one piece of information to guide the medical provider in a return to duty decision. Exertional heat illness is a serious condition. It can be a true medical emergency with multiple organs and systems involved. Medically, it's better to immediately treat for the worst case scenario than to not treat. For some heat illness patients, proper cooling is medically essential. Otherwise, it's as if they were never treated at all. Long-term impacts and death from exertional heat illness are avoidable. It requires awareness and prevention, and when needed, accurate temperature assessments, prompt and aggressive medical evaluation, treatment, and a medically supervised follow-up leading to return to duty.